Okay, so hello everyone. Today we have the pleasure of being joined by Dr. Musa Sani Musa, and he's a senior MRI radiographer who works at the Sheffield Teaching Hospital in the UK. And today he will be talking to us about MRI safety and artifacts. So whenever you want, the floor is yours. Thank you.
Right. Okay. Thanks, Marina, for introducing me. Thanks to everyone who has joined this meeting. As Marina has said, my name is Musa Sani Musa. I'm a senior MRI radiographer in Sheffield Teaching Hospital, Sheffield, England. Right. I have been in this profession for over, I would say, roughly 10 years. But full-time MRI, I would say 6 years, as I have done other imaging modalities as well. I know I've been given 1 hour to talk about MRI safety and MRI artifact. So at some point, I'll try to be rushing because I've got lots of slices to present. So I do encourage everyone to kind of interrupt me. You know, you can stop me if I'm too fast, or if you've got any questions, you can just put your hands up, or just speak out, and I'll stop and then try to explain further. So at the moment, I'm gonna share my screen. Okay. Just give me 1 second. I don't know if anyone can see my screen.
Currently, no.
No. Entire screen. So just give me 1 second. All right, just give me 1 second. I need to open the presentation. Entire screen. Can you see my screen?
Yes, now we can see it.
Right. Okay. So, right. So whenever we talk about MRI safety, this is the first thing that comes into our head, right? As we can see, we all know that these are medical devices found within every hospital, ranging from patient beds, wheelchairs, keys, coins, phones, wallet, credit cards, and what have you. So I'm sure all of us are kind of practicing radiographers, and we've encountered some of these items were within the hospitals. So why is MRI safety really important to us as radiographers, MRI radiographers in particular? I know this is like an MRI neuro course. So the reason why MRI safety is so important to us is because there are direct hazards to patient, hospital workers, patient relative, and other people as well. And we also have some indirect hazards that could affect, both patients, hospital workers, and etc. So I'll quickly rush into to the next slide. So when we do talk about MRI safety hazards, direct hazard, as we all know, the number one thing that comes into our head is projectile effect from ferromagnetic materials, such as keys, such as coins, oxygen tanks. Other direct hazard that we could encounter in our MRI department or MRI environment are thermal burns, are usually from RF burns. Also, we could also have a direct MRI safety hazard, such as implant malfunctions. I would take my time to talk about, implant malfunction, because I work in a neuro hospital where we have different specialties, as such as cardiology, neurology, and we have patients with all sorts of implants like neurostimulators, vascular stimulators, vagus nerve stimulators, cochlear implants, and we also have patients that comes with pacemaker. These are varieties of patients that we scan on a daily basis. So I would take my time to talk about this implant malfunction. Going into the indirect MRI safety hazards, The number one example is quenching. I don't know if most of us here have experienced quenching. I have experienced quenching where, in the middle of nowhere or without any, what do you call it, warning, we notice our MRI scanner quenching due to what you call it, rapid loss of the cooling system. So there are risks associated with what you call it, the quenching, because what tends to happen now is, okay, the room becomes filled with what you call it, helium gas. And as a result, if patient inhale this gas or any staff member inhale this gas, as we all know, there is loss of oxygen within the MRI room, which is being replaced by helium gas. The number one thing that would happen is asphyxiation. Also, this another indirect hazard that could arise from MRI scanning is what you call it, the noise induced by the changing magnetic field, which is the gradient coils. Okay, so now that we've seen some of this hazard, which I've just briefly talked about, I'm going to go into details, about this MRI safety hazard, both direct and indirect. As MRI radiographers, it's our responsibility to make sure that these hazards are controlled, because there is a potential risk if safety is not being checked or being approved. So that we have a lot of safety risk from such implants, or what do you call it, or materials that are taken into the MRI room. So the whole of this, what do you call it, these items that I've put on my screen now, like guidelines and legislations, the local rules, the standard operating procedures, that's what SOP means, standard operating procedures, management, controlled access areas. We've all seen this where, we have signs put on our doors, within, what do you call it, the MRI room, on the floors, everywhere towards, as anyone approach the MRI department, they tend to, what do you call it, see all these signs, which is warning them that, strong magnetic field is always on. Authorized persons, who are these authorized persons? We are the authorized persons, because we are, what do you call it, MRI radiographers. We have to check patients, staff members coming to the MRI department, and other people that are attending to the MRI department. So it's our responsibility to make sure that everyone is safe to go into the MRI controlled access areas. We've got screening forms as well. We've got labeling, and we've got training. So from these methods of controlling hazard, now what we are doing at the moment is what do you call it, the training aspect. We are educating ourselves. Mind you, we are all MRI radiographers in our own several departments. We have our own policies and procedures, how hazards can be controlled. We at some point, I've come in contact with patients with all sorts of what do you call it, materials that are unsafe in the MRI environment. So we're here to discuss these things and kind of try to educate ourselves, train ourselves, and then try to prevent any near misses or any potential risk to the patient and everyone attending to the MRI department. So we all know what's contained within the MRI machine. We just see it from outside is a nice looking scanner covered all in cases. But what's within the MRI scanner? We've got our static magnetic field, which is B0. We've got our gradient field, which is rapidly changing dB dt. And then we've got our radio frequency pulses, which is what you call our B1. So each of these part of the MRI system has potential risk or potential hazard. And we are going to talk about this in more details as we go ahead. So talking about the magnetic field, what safety issues do we, what safety issues can we likely come across as a result of the strong magnetic field? So the number one thing is, what do you call it? We have biological effects. I don't know from your own end, from my own end, I've come across patients that tells me, oh, look, I'm feeling nauseous. I feel like vomiting just by taking them into the MRI room. There is a reason for that, which is one of the biological effects of the static magnetic field. Projectile hazards, we all know if you take a key, a coin, any oxygen cylinder, etc., if you take them into the MRI environment, we all know what's going to happen due to the ferromagnetic nature of these materials. Implanted medical devices, also are being affected by the strong magnetic field. And then peripheral equipment, oxygen monitoring devices are all also affected by the static magnetic field. So, static magnetic field. So now, how does I know I've watched some video, and I think I've got a link to share the effect of this static magnetic field on ferromagnetic objects. I don't know if anyone have seen this video or you've noticed when you take a material. We've got Faraday cage, and we've got so how the magnetic field affects certain implants or certain ferromagnetic materials as you take them into the MRI room. So the closer you are, just at the bore of the magnet, that is where there's the area of maximum spatial gradient, as opposed to, say, you're just going into the MRI room. So this also has an effect on certain certain implants or certain medical devices, such as pump injectors. How far do you leave these materials to the bore of the magnet due to the effect of the static magnetic field? So, like I said, with the biological effect, so interaction of the body with can result in creating electrical potentials, vertigo, nausea, metallic taste in the mouth. I don't know if any of you has come across this from your patients, but as I said, I have come across patients, that are feeling nauseous by just going into the MRI room, and this is as a result of the biological effect of the static magnetic field. So now talking about ferromagnetic material, as we all know, there are two things that usually happens when you take a ferromagnetic material into the MRI room. One is what you call a projectile effect, and two is a torque. We know torque is like a rotational force that affects certain implants within the body. So you might feel like, oh yeah, my patient is safe, but then this patient tells you that, look, I've got a chisel, or I've got a injury from metal in my hand. You'll be like, oh yeah, that's fine, come in. And then when you finish scanning your patient might tell you, oh look, actually, I felt something moving in my hand. So if that object that's moving in the patient's hand is close to a delicate organ, such as the blood vessels, you know what's going to happen to the blood vessels. So we shouldn't take anything lightly during during our safety checks. We have what we call MRI safety experts. These are people, usually clinical scientists or MRI physicists, who have an in-depth knowledge of implants, MRI safety, and these are people that would be able to advise further on what to do, how to go about scanning patients that have got certain metallic injury, and what have you. Or okay, if a patient like is going into the MRI room, so with materials that are that could be potentially exposed to the projectile effect from the static magnetic field. So we have to be very, very careful with all materials that go into the MRI room. As I said, I work in a very busy hospital. We've got patients that have come from the wards, patient under general anesthesia, and intubated patients that have come with all sorts of monitoring devices. So it's your responsibility as the MRI radiographer to check to make sure all the devices that this patient have come with are safe to go into the MRI room. Oxygen cylinder, we know for sure there is no MRI conditional oxygen cylinder. Scissors, no. So firefighting equipment like fire extinguishers, and some materials are MRI conditional. And as we proceed further, I will talk about these materials. So still the effect of static magnetic field on some implants in the body. I don't know if you guys have scanned aneurysm clip, aneurysm coil, pacemaker. I have scanned patients with all these medical devices. These devices are MRI conditional, not MRI safe. They are MRI conditional. How then do you make sure, like, okay, the conditions have been met? You get this, you go ahead scanning this patient based on the device from the MRI safety experts. Usually, the most general conditions for scanning such implants are, okay, fine to proceed on 1.5 Tesla or 3 Tesla, maximum 3 Tesla. Okay, We know different types of scanning mode. We have normal SAR mode, we have first level. So usually most of these implants are safe to scan on normal SAR mode. Orthopedic implants like hip replacement, knee replacement, shoulder replacement, what do you call it, MRI safety conditions as regard to the, what do you call it, static magnetic field. So most of these implants, due to technological advancement, some of these implants are ceramic, some of them are titanium, which we all know these are, what do you call it, safe to proceed under 1.5 Tesla or 3 Teslas. So, like I said, such medical implants that are, what do you call it, are MRI conditional, not MRI safe, MRI conditional. The questions now that we need to ask ourselves is, how confident are you to meet these MRI conditional requirements in your practice? Do you have any MRI safety experts? Have you come across a patient with MRI, what do you call it, with MRI conditional implants like pacemaker, aneurysm clip, aneurysm coil, nerve stimulators, what do you call it, neurostimulators or vagus nerve stimulators? Have you scanned any of these patients? Or what is your practice in your hospital? Is it that when any of these patient comes to you, you just send them away and then tell them, you know what, sorry, unfortunately, you cannot have a scan? So yeah, it all depends on your own standard operating procedures, what you do in your local department. In my department, we scan patients with all sorts of implants. And this is the reason is we've got MRI safety experts. We have a dedicated team of MRI experts who does all the MRI checks and then, what do you call it, tell us what the conditions are. And then from our own end, we're being trained to check these conditions, and we are confident to say, oh yeah, the scan or what do you call it, we've met these conditional requirements to carry on with these scans. Right. Okay. So still with this strong magnetic field, which is the main magnet, we've got a passive implant. These are not active implants. Passive implants such as hip or knee replacement devices, stents, clips. We know these are not active implants, so they are not electronic. They are just device like stent is just open blood vessels. Aneurysm clips or coils is just to, what do you call it, to clip an aneurysm. Whereas the active implants are pacemakers, neurostimulators, cochlear implants, pain relief stimulators, or insulin pumps. So these devices, like I said, I've scanned all these devices. All you need is just to make sure the conditions are met. You've got the dedicated team, to support with scanning of these equipments. Right. So still on the, what do you call it, static magnetic field monitoring equipment. So for example, now SpO2 monitor, just monitor the patient, is a SATS probe just to monitor the patient oxygen saturation. It looks electronic there, but it's MRI conditional. Most inpatient patients under general anesthetic anesthesia are, what do you call it, being monitored to make sure their, what do you call it, oxygen saturation is being monitored, or what do you call it, ECG monitoring devices as well. They are attached to patient. So the question now is, do you have the support? Do you have the equipment? Do you have the training to make sure, okay, all the conditional requirements are met before these devices can go into the MRI room? Also, another, what do you call it, another safety consideration with regards to the static magnetic field is intraorbital foreign body, IOFB. So you've got a patient that has come to you, oh yeah, I used to work in the metal industry, and while I was, what do you call it, welding, I had, some bits of metal gone into my eyes. The question now is, have you been to the hospital? Has it been washed away? I'm not sure. I think it has. You don't take I'm not sure for an answer. You must establish that there's nothing in the eyes. What could potentially happen if there is metal in the eyes? Like we know, the eye is a delicate organ. We've got optic nerve. Like I said, we have attractive force, and then we have torque or rotational force that, what do you call it, that can be affected by the static magnetic field. This could potentially damage the optic nerve. So this needs to be checked. How close it is to the optic nerve. Is it within the globe? it needs to be checked. How? CT or X-ray, as simple as that. In mitros, a patient has been working, has worked in a metal industry and who has come to us for an MRI scan of any part of the body, we have to make sure, we've ruled out that there's nothing within the orbit. So that's that about the static magnetic field. There are two main safety concerns with the magnetic field, with the static magnetic field, which is what the torque or the projectile effect. As we've seen now, some of what you call it materials can be forcefully attracted to the magnet. If anyone is within the vicinity of this, what you call it, this ferromagnetic material, it could be a needle, it could be what you call it, a coin, it could be anything due to the force of attraction, between the ferromagnetic material and the magnet. This could potentially cause a serious injury to the person within the vicinity. Right, going on to the time varying magnetic field. So we talk about strong magnetic field and the time varying magnetic field. This is our, what do you call it, gradient coil. It's time varying because it switch on and off quickly. And we know the function of our, what do you call it, gradient magnetic field is just to change, what do you call it, to change the magnetic field experienced by the hydrogen atoms within a particular slice within the patient body. So as it switches on and off quickly, rapid changes between switching on and switching off, it tends to make a very, very loud noise. I've had lots of patients that ask me, oh, why does your scanner make this very loud noise? This is the reason. It switches on and off quickly, pop, 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 and it's just trying to, it switches in different direction, X direction, Y direction, and Z direction. And this is to enable us to localize, to spatially encode our signals within, what do you call it, the frequency encoding direction and the phase encoding direction. So what are the possible MRI safety consideration with regards to the time varying magnetic field? So the number one thing is peripheral nerve stimulation. As this magnetic field changes, what do you call it? It could stimulate, what do you call it, causes some sensation within the body, the acoustic noise. And this is the reason why we give patient dual ear protection. I know of some vendors, the headphones is enough to, what do you call it, to serve as an ear defender, to, what do you call it, to reduce the noise from the magnet. Whereas with Siemens, you have to give double ear protection. You have to give earplugs and headphones, because the earplugs, headphones is not enough to, what do you call it, to protect the patient's hearing. This could potentially damage the patient's hearing. I think with Siemens, the headphones is usually 13 decibels. So that is not enough to protect the patient hearing. So we tend to give double ear protection. Also, what do you call it, biological effect? Like I said, peripheral nerve and muscle stimulation from the rapid changing of the magnetic field. Acoustic noise. So according to Public Health England, for an adult, so what do you call it, the higher the field strength, the higher the noise level. So in adult, it's 140 decibels, whereas in children, it's 120 decibels. So usually you tend to give patient earplugs and headphones in order to protect them from the potential, damage that can be caused by the rapid change of the magnetic field. Going on to the RF coil. So we know the main function of our RF magnetic coil, which is B1, is to what? To flip our what do you call it, magnetized hydrogen atoms into the transverse plane, and then it switches off. When it switches off, what do you call it? Our hydrogen atoms tend to return back to their, what do you call it, equilibrium level, or back to their, what do you call it, direction of the main magnetic field. And this is how we acquire our T1 and T2s. So with RF now, because it's sending an RF pulse, which is sending some, what do you call it, it's sending some, what do you call it, RF pulse into the body. Our radio frequency wave, we all know, is part of the electromagnetic spectrum. So it's sending in some RF energy into the body. As a result, there's what we call RF deposition. which depends on the flip angle, the pulse sequence, and the field strength. More energy is being deposited at higher field strength, 3 Tesla or 7 Tesla. Heating of tissues is the main safety concern with the RF magnetic coil. So still talking about the RF coil, there are two things that we need to keep in mind in order not to, what you call it, expose our patients, in order not to expose our patient to what do you call it, unacceptable level of what you call it, RF deposition. So we have to take what do you call it, we have to be careful or monitor our specific absorption rate. Like we said, okay, the average energy deposited into the body per unit mass, which is usually in watt per kg. And for majority of implants, so I think the whole body, what do you call it, maximum, yeah, the whole body maximum RF deposited energy is less than 2 kg per watt. This is the, yeah, less than 2 kg per watt. Whereas we've also got B1 root mean square. So how does this come into effect now? With specific absorption rate, taking accurate readings of the patient's weight and height is really important. I know some people used to be like, oh, well, roughly I weigh this and that. No, you need to know the accurate, what do you call it, weight and height of the patient, because this is what the scanner used to calculate the RF energy deposited into the body. You do not want to overheat your patient. Trust me, you do not want to, because some patient have got, what do you call it, certain implants, and some patient have got, what do you call it, temperature control issue, or for example, you've got pregnant patients, so which usually already what do you call it, the temperature is usually high. As a result, what could potentially happen is what we call RF burns. So it's really important, get the patient's weight and height so that the MRI scanner can calculate, what you call it, the appropriate specific absorption rate. And with regards to B1 root mean square, which is an average effective RF calculated, within, what you call it, the duration of the scan. Also, it has its own maximum level. This has nothing to do with the weight, whereas this is with the scanner or the particular sequence that you're trying to run. So also it's really important, if your MRI safety experts have given you, what do you call it, the conditions of implants. So do you know how to check these settings on your MRI scanner? Do you know how to monitor the patient to make sure you've scanned the patient within this acceptable level? So like we said here, okay, SAR varies with patient body habitus, tissue composition. We all know what's going to happen for a patient that is, what do you call it, slightly obese, or someone that is obese. So definitely the, what do you call it, the scanner is going to deposit more RF energy. There are certain ways you can, what do you call it, you can, what do you call it, try to mitigate this. There are some settings, say for example, what do you call it, sorry, I'm more of a Siemens person. So in Siemens, we all know that we've got, what do you call it, different options, such as, okay, changing your flip angle, what do you call it, increasing your TR, or reducing your number of slices. These are ways in which you can make sure you're scanning this patient within the acceptable specific absorption rate. Some scanners, they wouldn't even let you, proceed, with scanning the patient without having to choose one of these options to make sure, yeah, you've not overexposed your patient to, what do you call it, to the RF energy. So usually, like I said, we've got normal SAR mode, we've got first level and second level. Do you scan all your patient in normal SAR mode, or first level mode, or second level mode? Okay, it's really important, really important to scan your patient within normal SAR mode. Some patient, like I said, some patient with overheating problem, or some patient with, like, pregnant patient, you have to be really careful, or patient with implants, you have to be careful scanning them at first level, because what you're trying to do now is overheat the patient. As a result, they've got implants which can easily be overheated, and we all know what's going to happen. RF burns is number one, what do you call it, the likely, what do you call it, repercussion by scanning patient at usually first level or second level. So we should try and stick to our normal level if possible. these are just some information about the specific absorption rate. So how can we manage SAR now? Okay, so like I said, taking accurate weight and height of the patient, what do you call it, different operating mode, just making sure that we stick to the normal SAR mode if possible. How can we manage SAR? Okay, increase your TR if possible, reduce your flip angle, reduce the number of slices, reduce the number of echoes, breaks between high what do you call it, high SAR acquisitions, or what do you call it. So taking breaks now, someone might be wondering, why would I take a break between scanning one sequence and the other? It's what we call, like for example in football, when it's during extreme weather condition like 40 something degrees, they tend to be like a cooling break. So it's the same thing here. Okay, if you're scanning patient with certain implants, or what do you call it, in order not to overheat the patient, so after scanning one slide, you can give them like a cooling break for the body to try to return to the, what do you call it, normal body temperature, before you can then proceed to the next sequence. It's another way of managing SAR. So this is B1 plus root mean square. Like I said, this one has nothing to do with, what do you call it, the body weight. It's got to do with, what do you call it, certain types of implant, and it's also relies on the region of interest. So this is for this is from Siemens. I don't know how this looks on Philips or GE scanner, but this is on a Siemens. So this is how you can monitor your patient. When you go to SAR information, it tells you where you've got, what you call it, your B1 plus root mean square, just making sure you're scanning within the acceptable, or what you call it, acceptable level. So on a normal SAR mode, this is it. If you go to a first level mode, it changes. So this is how you keep track, just to make sure you're scanning within the acceptable limit. Oh, also another way to just what do you call it? Like, I know we all do it, but it's still important to make it part of our daily routine. Okay, when you're scanning a patient, that, what do you call it, kind of is gonna like squeeze into the, what do you call it, into the bore. So just make sure you put some padding in order to, what do you call it, in order to, what do you call it, reduce induced current or RF bonds. So just trying to avoid contacts, putting pads in between the legs, between the hands and the thigh, just at the side of the, what do you call it, shoulder. So any part, of the body that might be touching the MRI, but this is just to make sure, you're trying to avoid any RF bonds. So contact bonds, like we all know, cables, monitoring equipment, transdermal patches. Yeah, this is very common here now. We have a patient with, okay, what do you call it, pin relief patch, nicotine patch, HRT patch. All these patches, there's a possibility that these patches might, what do you call it, might heat up during the scan and burn the patient. Even some ECG stickers that are not MRI compatible. Not every ECG sticker is MRI compatible. So you have to make sure whatever is talked to the patient is MRI compatible. If not, you might just burn your patient. Or with also these transdermal patches or nicotine patch or HRT patch. So if these patches don't heat up the patient, the other thing is, like, it can lead to overdose, whatever is administering into the patient, because due to the rise in temperature of this what do you call it, patches, the patient what do you call it, can have overdose of such medication. Even sporting sport clothing as well. So there's been a report of, what do you call it, metallic fibers within clothing, and there are, there's been some serious concern. So make sure you just get your patient changed into hospital gowns if possible, to avoid such. Yes, also, some people might be wondering, okay, makeup, piercing, and tattoos. Yeah, I know it's common now due to trending, due to trend. So sometimes you have patient with false magnetic eyelashes. Yeah, we know what's gonna happen if you take your patient into the MRI room. Even some what do you call it, body piercing as well, and then some makeup, some of the, what do you call it, mascara, I don't know the names. Yeah, some makeup, they have some metallic bits. tattoos as well. Right, in the UK, I think there's been what you call it. There's been a serious awareness. So most of the tattoo artists now, the ink which they use to design all this, what do you call it? The tattoos now are non-metallic. But usually in the past, some of these tattoo inks have got some metallic. The ink has got metals, and then you have cases where patients are what do you call it? Being burnt as a result of having these tattoos. So how can we control hazards now? Who is responsible for controlling this hazard? Is it you? Is it your manager? What do you call it? Is it your the CEO? Whoever, So you as the radiographer, you're the MRI authorized person. So it's your responsibility to make sure anyone going into the MRI room is safe, or MRI environment is safe to go into that environment. So these are the list of people that are what you call it responsible. So the MRI responsible person, the MRI safety expert, the authorized person, the MRI operator, these are the people that are responsible. Day-to-day responsibility for safety in MRI department, this is the role of the MRI responsible person. I'm sorry, I've just looked at my time now, so I'm gonna quickly whisper through this. So yes, it's our duty and our responsibility to make sure that anyone coming into the MRI room is safe to have a scan. MRI safety expert, I said, you can have medical physicists, MRI physicists, or clinical scientists. They, what do you call it? Their duties is to provide scientific advice to the MRI department. Authorized person, okay, you are the authorized personnel. Okay, anyone, you are the one that gives authorization for anybody coming into the MRI room. Yeah, still the same. Okay, these are the categories of people that can authorize for anyone to come into the MRI environment. Okay, so category A, this is where we belong. Okay, every scanner, every MRI department, every MRI environment has its own, what do you call it, design and control access areas. So the doors are controlled. The door into the MRI department should be controlled, only accessible by the MRI authorized person. The door into the scan room also is a controlled access area. These are the signs. We are all familiar with these signs in controlled access area. It says no to this, no to this, no to this, no to this. Right. Some of these are what do you call it? We know what the colors mean. Okay. Stop, unsafe. Okay. Yellow, or what do you call it, is conditional, and then green is what do you call it, MRI safe. Usually on our monitoring equipment, it's just this yellow sign because they are all MRI conditional. So each device, anything coming into the MRI environment needs to be labeled MRI safe, MRI conditional, and MRI unsafe. So these are items that can pose unacceptable risks, and therefore they shouldn't come within the MRI environment. So we've got some MRI safety guidelines and legislation. Yeah, in the UK, they don't joke with these things. They take it very seriously. So they are, what do you call it, health and safety, the control of electromagnetic field at work regulation. There's so many regulations. The medical and healthcare regulatory agencies that regulate, all medical equipments to make sure they are safe. The design of the MRI environment, everything. So you have to follow. It's your responsibility, your manager's responsibility, is everyone's responsibility to make sure everyone is safe. Right. You've got a patient request from a doctor saying to you, oh yeah, I need an MRI scan of the brain for my patient. And then the next thing, okay, the doctor tells you, oh, trust me, I'm a doctor. Yeah, this patient is safe. How does he know he's safe? I'm sorry, you are the authorized person. You are within the department. You are the MRI safety expert. You, the MRI physicist or the clinical scientist, it's your responsibility. Just because the doctors, tells you, oh, yeah, it's fine. No, you have to check. Do not trust anyone. Trust me. We've seen lots of stuff, we've seen so many errors, so many mistakes, so many, what do you call it, safety concerns. So it's your responsibility to make sure you check your patient before they go into the MRI room. The doctor's responsibility is make sure they've done their own checks. If they are referring any patient, make sure they've done their own safety checks. But then when the patient comes to you, you have to complete what do you call it, a safety form. Right. So there are some patients, due to language barrier, some non-English speaking patients, what do? Use an interpreter. Okay, unconscious patient, you need to make sure whoever is referring this patient for a scan, the safety has been completed. There's what we call a clinician safety form, where the doctor fill in the form according to the patient's medical history, or whether speaking to a family member, just to make sure to establish, like, okay, this patient is safe to proceed. If at all there isn't any information, okay, check the patient previous scans. Have they had an CT scan or X-ray of the brain, CT scan of the chest, to make sure they've not got a pacemaker or they've not got any implants in the head? Yeah, this what do you call it, scans can give you an idea, okay, and can help you establish whether it's safe to carry the patient into the MRI room or not. So this is a sample of our MRI safety questionnaire. Why do you ask? Like I said, the list, okay, you have to have a lot of stuff to ask just to establish, okay, the patient is safe to go into the MRI room. Pacemaker, all these are active implants, pacemaker, internal cardiac defibrillator, loop recorders, or any cardiac device. If the answer is yes, oh, I'm sorry, you're not having a scan today. We need to establish it's safe to have a scan. Surgery to the head, heart, spine, eyes, or ears. Yeah, the answer is yes. What have you had? Is it a minor surgery? Oh, what do you call it, perforated eardrum? Oh, yeah, that's fine. Oh, I've got laser eye surgery. That's fine. Oh, what do you call it, prosthetic eye? Is still fine to scan according to my own local, what do you call it, local policy. What have you had in your spine? Oh, just some metal rods in my spine. These are non-active implants. They are safe to scan. What have you had done to your heart? Is it loop recorder you've got? We check our own MRI safety policy, whether it's safe or not safe to scan. If it's a conditional, we make sure the conditions are met. Having our cardiac physiologist at the time of the scan, just to make sure patients have their scan and it doesn't stop any of their treatment. So it's good to know patient past medical history. Yeah, screening form needs to be completed. Pregnant patient, we scan what do you call it, MRI obstetrics. So on a day-to-day basis, we scan pregnant patient. So this is just some, what do you call it? I've just put up this some of the how, what do you call it, a safety policy looks like. So this is vagus nerve stimulator. These are the kind of checks, rigorous check we follow. Okay, is this device documented? What is the make of the device? What is the model number of the device? You have to go through all of this flow to establish whether it's safe to go into the MRI room or no. You refer to the MRI safety experts. Aneurysm clip policies. So in your own trust, also, you have to make sure you've got all these policies, which is what you call it, there for you to make sure, like, you've established the person is safe to proceed with a scan. What you don't want is cause serious damage or death to your patients. What do you call it? Cerebral spinal fluid shunt policy. Yeah, it's safe to scan. We scan them. If it's unsure, it needs to be checked. All we want is that, yes, okay, yeah, I've had this shunt, I've had a scan before. What kind of, on the left here, we've got make a model number, and then this is the field strength. It tells you whether it's safe to scan on, what do you call it, on certain field strength or not. Cardiac monitoring device policy, detached retina. If a patient have had surgery where, of a detached retina, and if the retina has been replaced, what kind of method did they use to put back the patient's retina? Is it vitrectomy? Is it laser? Is it, what do you call it, buccal? Whichever one they use, we need to find out through rigorous check to establish, oh no, this patient is safe to have a scan. Intracranial pressure, what do you call it, shunt, orthopedic implant, and so on and so forth. I've left a link here. It's just a short link, what do you call it, video about what do you call it, MRI safety, if anyone is interested. I know there's lots of videos out there, but so yeah, I think I've come to the end of my presentation on MRI safety. The moderator, do you want me to continue on to MRI artifact, or is there anyone that wants to ask any questions?
Yes, please. If anyone has any questions, feel free to unmute yourself and ask them, or otherwise write them in the chat. And then if you like, we can continue on to the artifacts part. But yeah, let's wait a couple of seconds and see if there are any questions.
I have a question.
All right, go ahead, Mr. Eric.
I see you displayed the MRI capnography equipment or capnography device.
Yeah.
For measuring ETCO2 and measuring heart rate and
Yeah.
oxygen and blah blah blah, physiological parameters.
Yes.
The length of the cannula is not long enough to, maybe you want to measure the patient's physiological parameter while the patient is on the MRI scanner. The
Yeah.
length of the cannula is not long enough. Is it possible, maybe you want to run a research, is it possible you can take that capnography equipment into the MRI machine and strap it on the MRI couch while the patient is on the scanner, and then you can measure your physiological equipment? Or will the magnet affect the physiological reading of the equipment?
Right. Okay. So with these physiological monitoring devices, like you said, the cannula, which I assume is just, that little wire between the, what do you call it, SpO2 probe
Yeah.
and the device itself. So
Yeah.
everything goes in with the patient. They are MRI conditional. So everything goes in with the patient. Like they'll sit on the patient. And
so my MRI conditioner means it can
okay,
go into the MRI scanner?
yes, yes. So with MRI conditional is that these devices can go into the MRI room under certain conditions. What are these conditions? Okay, the strength of the magnet. Is it a 1.5 Tesla, 1 Tesla, 0.2 Tesla, 3 Tesla? These are examples.
Okay, we are targeting 1.5 for that one.
Yes. So we use, we've got 3 Tesla here and we've got 1.5 Tesla. So all these devices, they have what you call a label attached to them to say they are safe to go into the MRI room. They are conditional and the conditions have been met to go. So all those monitoring devices that I've just displayed here, they all go into the room with the patient.
Perfect. Thank you.
No problem. Is there any other questions?
No. Thank you for the presentation. And I just wanted to be sure, although I missed a little part, but I was going to ask about if you did touch on MRI and contrast in terms of safety. Did we touch on that?
No,
Because
no, we didn't.
we did.
No, we didn't.
Because I actually I've been thinking, first of all, is there still, as it were, maybe by your local policy or something, if you can share some insights on, is there a routine need for creatinine kidney function investigation for administration of contrast in MRI? Is this still something that is still widely practiced? Because I've had discussions and seen some articles that suggest that it might not be necessary in every case. And then in terms of the linear and the macrocyclic types of contrast, what is the convention like? Because I know in some parts of Europe, I think they tilted towards the macrocyclic and then some towards the linear. Do you have anything to say concerning that? Yeah.
Yeah. So what I would say, first of all, is about EGFR. So in my own local policy, we have, what do you call it, IV intravenous, injection and pregnancy policy. The only time we check for EGFR is when administering Primavist. So Primavist is what do you call it, liver-specific contrast agent. That is the only time we check EGFR to make sure the EGFR is greater than 30. Anything above 30, proceed. Whereas when we're administering Gardavis, Gardavis or Doterem, these are the what are two most, what do you call it, frequent contrasts that we use. We don't check EGFR, we just proceed. So it's already been approved by what you call it, the urologist, they've already approved it, like then also our radiologists have also approved that, what, you don't need to check EGFR for this contrast agent. Unlike CT scan, which they use a different contrast agent, omnipaque, and the quantity of the contrast they give, so in MRI, we give contrast according to body weight. Usually when we give deuterium, it's 0.2 mils, per kg, whereas when we give Gardovis, it's 0.1. So usually if a patient is, 100 kg, you give 10 mils. Whereas in CT, trust me, you're going to give 100 mils. So it's kind of insignificant. This is why we don't check EGFR when we give all other, contrast agent. That's one. Your second question, sorry, remind me.
Yeah, thank you very much for the first answer. I've been thinking along the same lines too, but I really appreciate that. So I was asking about the linear and the macrocyclic types of contrasts, and if you actually have anything to say about, because there is the old talk around the chelates and then the deposition in some parts of the brain post-investigation and all of that. Is there really
I would like to,
yeah.
Samuel, I wouldn't want us to deviate from the discussion for today. I know the issue of contrast is quite wide and expansive, and if we have to manage our time very well, he has not even touched MRI artifacts at all.
Okay.
So if we want to go so deep into contrast, we might deviate a little bit. So will you permit us to take MRI artifact section? And then if we have 5 minutes, we might, and he wants to dwell on that, we might. So Doc, we can still give you about 10 minutes for the MRI artifact. And then if you have 2 minutes to spare to look into the acrylic MRI contrast you talked about, fine. Yeah, if not, we can send it via email to you.
Right. Okay. So thank you very much. I will quickly, I've not got much slices on the MRI artifact. Right now, this is something we are all familiar with. Like I said, we are MRI radiographers and we are familiar with, most of these things. So I've tried to narrow my presentation on just few MRI artifacts, because we're talking about the brain. This is a neuro, this is a neuro course. So we're talking about the brain. There are some other artifacts such as chemical shift artifact that I've not talked about here. So I'm just sticking to MRI artifacts that is, mostly affect the brain. So we all know what artifact is, anything that shouldn't be there, when our image is being reconstructed from our, so it's what we call an artifact. As we can see here, there are some artifacts. I've just displayed some, I think, we've all come across some of these artifacts. So the common types of artifact, which is the motion artifact, the susceptibility artifact, the wraparound artifact, we've got a chemical shift artifact, and we've got RF artifact. So we know where, what is the common source of the, motion artifact is when a patient is moving. There's periodic motion and there's random motion. So if a patient is moving all the time, we know what's going to happen to our image. It looks like a ghost, ghosting artifact. And then we've got just some random motion, of the head. Okay, maybe somebody have a cough or something like that, and if affect the pictures where we get like just a blurring of the image. So one important thing to know is that, okay, all these artifacts, how do they affect our image? Because like I said, we all know what K-space is, what K-space is, and our K-space has our, has information about, the slice, the frequency encode direction, and the phase encode direction. So most of these artifacts, most of this artifact affects, they are pronounced on the what they call it phase encoding direction. And the reason why is phase encoding direction takes long. When trying to reconstruct the image from K-space into the image, what you call it, domain. So phase encoding direction is very slow. And this is why if there's any random motion or what you call it, periodic motion affects the image. Whereas the frequency encoding of our signal is very quick, very fast. So there's little chance for any motion. Now, you've got a patient that's constantly moving his head, artifacts on your image. How do you minimize this artifact? We all know, okay, what would you do? First is talk to your patient. Oh, Mr. X, can you please stay very still? There's a lot of motion on your scan. I'm sorry if you keep moving, the image is gonna be, distorted, or what do you call it, by artifact. So talk to your patient. If your patient still, isn't listening, most of these vendors, still, I'll give example with Siemens, they have what you call it motion reduction sequences, such as blade sequence, which I think in GE is called, propeller. Yeah, GE calls it propeller. So you can use what do you call it, this software to what do you call it, mitigate the patient motion. Otherwise, what else you can do is to speed up your scan. Siemens use parallel imaging such as Grappa, which, if the sequence takes 4 minutes, if you activate Grappa, it brings it down to half of the scan time. What Grappa does is, what do you call it, instead of scanning the whole, what do you call it, the whole of K space, it scans half of K space. And then because what do you call it, it's like a mirror image, K space, the half of K space and the remaining half is like a mirror image. So Grappa uses just half of K space and extrapolate, or what do you call it, assume what is going to be on the other side, and then it gives you your image. So it's a way of speeding up your scan just to mitigate patient motion. So use software like Blade or Propeller, speak to your patient. These are the possible ways. And if it's an inpatient, what do you call it? If the patient thinks they cannot keep still and it's really important to do the scan, then, you can just administer, we don't administer. So the doctor prescribe them with mild sedation just to, knock them off when they come for their scan. Or, what's, case scenario is, do the scans under general anesthesia. Susceptibility artifact. So we know, due to what you call it, the aging population, we've got not even the aging population. Sometimes, some people even use what do you call it, dental correction braces, and then some patients, they have dentures and what have you. So susceptibility artifact arise when there is a difference in magnetic field between two items within the scan field of view. You've got the MRI scanner trying to, what do you call it, magnetize hydrogen atoms. You've got metal, usually ferromagnetic metal, and you've got the tissue, which is usually diamagnetic. So you've got ferromagnetic, you've got diamagnetic. These differences is what affects, what do you call it, the image quality. So now some of this, what do you call it, this within the scan field of view, the scanner is trying to, some of these materials are trying to, what do you call it, bring together the magnetic field, strong magnetic field, and some of these implants are trying to weaken the magnetic field. What then tends to happen is you either get what you call it signal loss or signal pileup. This is what happens, what causes susceptibility artifact. Also, one might be wondering, Brad, why is hemorrhage also an artifact? Yeah, hemorrhage is susceptibility artifact because blood hemoglobin contains, what do you call it, contains metal. So on some certain sequence, and this is why we when you scan a patient using gradient echo and what do you call it, SWI, this particular sequence are very good for detecting minute blood. They are very good for detecting blood because they have high susceptibility to metal artifact, and hemoglobin contains metal. How can you minimize? There are certain ways you can minimize susceptibility artifact. If it's a denture, an elderly patient with denture, just ask him, can you please take your denture, out? It solves the problem. What else can you do? Short echo time, the time it takes to, the time it takes to sample the signal. If you use short echo time, for example, now when we do like, if you use a gradient echo, 20 millisecond, it's totally is a waste of time, because like you're not going to see, the image is not going to be diagnostic. So instead, there are some 3D sequences which have very short TE of 2 milliseconds. They give you good image. Spin echo sequences, it could be fast spin echo, turbo spin echo, as opposed to gradient echo. Like I said, gradient echo is very, very susceptible to metal artifact. So you have a patient that's got metal in the head, metal plate. Why run a gradient echo sequence? Because your image is going to be distorted, or even a diffusion weighted scan, which is very susceptible to metal artifact. Like, it's pointless. It's not going to give you what you want. Parallel imaging also, which uses half of K space, tends to reduce susceptibility artifact. You still see the artifact, but it's not as pronounced as when you've done like a full scan. There are some also metal reduction, metal artifact reduction techniques. These are software, like it's not every scanner that has them, because there's a software, and these scanner companies have you have to pay to get the software. Example is a CMAC. So if you've got CMAC, it's designed in such a way that it reduces the artifact from from the region of interest. You've got Maverick. These are all specialized metal artifact reduction technique. And also, from your own end as an MRI radiographer, if you want to reduce susceptibility artifact, what you can do is, instead of using thick slice thickness, use thin slice thickness. That's high-res scan. Use high bandwidth, because if you use a narrow bandwidth, you're trying to concentrate all your signal in one place. So try to spread it out. Use high bandwidth technique, which then spreads the metal implants within the region of interest, and that tends to reduce the metal artifact on your scans. What else you can do is, small voxel size. This is by using increasing your matrix size, just to make sure your voxels are small. If you've got big voxels, that's big coverage, and then you have more susceptibility artifact. So these are some ways you can use to reduce susceptibility artifact. Like I said, spin echo, it could be fast spin echo sequence, or turbo spin echo, which is the same, or just spin echo sequence, because they have a refocusing 180 pulse sequence. So if on gradient echo doesn't have a 180 refocusing RF pulse, that's why it's largely affected by susceptibility artifact. Whereas spin echo, there's 180, you do your 90-degree, you do 180 refocusing, 180, 180, 180. Those 180 try to bring those hydrogen atom back in phase, and then boom, acquire your scans. Phase wrap, as the name implies, phase wrap, it happens in the phase encoding direction. So usually it's when you've got a small field of view, so you have your anatomy outside of your field of view. What can you do to minimize this? Use field of view appropriate for that region of interest, or use phase oversampling to mitigate phase wrap. And then we've got RF interference. Sometimes you might see an artifact on your image and you keep wondering, where is this coming from? So it's just RF interference. Sometimes the light bulb you use in your scan room can affect, your images. So because you've got RF, RF false, and there's RF, interference or the Faraday cage, or you've left your door open, the scan room door open. So any small errand signals can affect your image. What can you do to affect this? Just check your doors, make sure your door is locked properly, check cables or any electrical equipment, and then boom, problem solved. Like I said, I'm not going to talk about chemical shift here. So just to conclude this now, this talk on MRI artifacts. So MRI can suffer from many different artifacts from different sources, body physiology, hardware, accusation. So it's really important to identify and address this artifact. So as an MRI radiographer now, it's now your responsibility to check, right, where is this artifact coming from? And then ways you can use to mitigate, or what do you call it, correct this artifact, just so you can achieve good quality diagnostic image. So yeah, that's the end of my talk on MRI artifact.
Thank you very much. Again, if anyone has any questions, feel free to unmute and ask, or send a message in the chat.
So I believe one of the reasons were, sorry, I have an addition, not a question. Now, because we are dealing with advanced sequences, these sequences such as ASL, DTI, fMRI, they are very susceptible to artifacts, and they are very sensitive. The importance of helping us know some of what we should do, or some of the things we should put in place before we carry out these sequences, just to forestall the appearance of artifacts on our image, is very important. For me, one of the things I have learned while we are doing these advanced sequences is basically, especially when we are positioning patients for advanced sequences, we could we could overlook the importance of using foam pads to immobilize the head. Yeah, we could overlook that when we are dealing with just anatomical scan. But then when we are dealing with, say, fMRI, these sequences are very sensitive. And then it is very important, if you have any way to immobilize the head of the patient ahead of time, to forestall even the smallest, image artifacts on the image, not to degrade the image in whatsoever. Even if you are to apply all this parallel imaging you have talked about, perfect. So good, you have made us know about this, and I'm very glad you made it as simple as possible without too much of technicalities for those of us who are just coming into MRI for the first time. So that is my little contribution. Yeah.
Thank you.
Thank you.
Thank you, Musa. Just to add a bit to the MRI safety. Oftentimes than not, we overlooked the fringe field within the MRI environment. But some of these may extend outside the MRI scanner. And any person who is coming in contact, you might not know, maybe that person having, pacemaker or anything, and it comes in contact with that. That can cause dysfunction of the pacemaker, and that may result in hazard. So just to add a bit of that to that. And also there will be a bit of interference of like the RF pulses when there's some interference of a signal within that, what do you call it, field.
Fringe field.
Yeah.
Fringe field, yeah, that's correct. Yeah. Thank you very much, Francis. Thank you.
You're welcome.
Okay, Marina, up to you. I think we have extended our time by 12 minutes, which is perfect. So I leave it for you to conclude.
Yeah. Okay, if there are no further questions, I'd like to take this moment to thank you again for your time and for your great presentation. And yeah, I'll end the recording here. Thank you very much.
Thank you. And like I said, thanks to everyone.